more, so I want to wade right into it. And I want to start with a question for David. I was really struck by his anecdote about, from one day to the next, there were no more paper records, there was an electronic record. I'm interested to know who has the power to do that, and I wondered if in our system anybody would have I'm thinking of a better word than the fortitude to do that from one day to the next. So how does that happen?
Yeah, so I think it really evolved under a gentleman named Ken Kaiser, who was at the VA. And Kaiser was really a sort of visionary, and he, even though he was an appointee, political appointee, he really stuck his neck out on a lot of things, thinking that he would eventually get sacked. But he kept doing things that he didn't get sacked for, so he just kept doing them. And he was during the Clinton administration. And then he actually stayed on when the first Bush was elected, and he thought for sure he was going to get sacked, and he didn't. But I think it was probably the fall of 1998 was the night that this went active. And I should have been paying attention more than I had, but it was just one of those sort of day things that said, from this point on, you can't do it. Now, after that, though, one of the interesting things that happened was that there was a big push to outsource, to buy a third-party vendor system, and that was during the Bush administration, because there was a big push in everything to just outsource it. Instead of having the government do it, the private sector can do it better. And I think they spent about $500 million on a number of contracts that went absolutely nowhere. And so they came back full circle to sticking with the system that the VA developed. And so they were able to do it because they had started the system, and then they said, we're going to do it, and he picked the date, and they did it.
And Mike, you know the Alberta health system really well. Could something like that happen here? Could we make an instantaneous decision that makes care better?
It might cost a bit. Yeah, I mean, there is talk about a clinical information system for the province, given the situation we're in. I must admit my own bias would be taking advantage of the systems we already have in the information. I mentioned earlier HQCA is helping get information out so physicians can look at their performance compared to others. We've been trying to do a project on secure messaging so you can communicate more. So in a lot of ways, in the next while anyways, I'd like to even make take better advantage of the systems we have. I do think the other aspect is, and good, and Carl Amrine can probably answer better than I can whether or not the investment will be available, but it would be a significant investment.
Okay. And David, you have some experience with bringing in EMRs. It works well locally. Why don't we scale this stuff up? We know that it works. Eventually people like it. Why don't we do it?
Why don't we do it is a great question. Part of it is sometimes I think fear and worry that it's going to impact our system. But I'd go back to our younger graduates. They will not take over a practice that has paper-based charts. They won't do it I'm sure there's exceptions, but 99% of them will say, I will not take over a new practice or an old practice that is paper charts. I'll only go electronically. And when we co-located all of our physicians into one building about 10 years ago. And the simple solution that we had was we didn't put chart racks on the door. And so the doctors started putting the charts outside on the floor. And once they'd been kicked a few times and scattered to the winds, they gave up and moved to electronic charting. It really is, it's a matter of saying, as a system, we are deciding to do this. And in Ontario, they did it quite effectively in terms of billing. You could no longer submit the old cards, paper cards. You had to do it electronically. And it was amazing. All of a sudden, every single doctor in the province submitted their billings electronically.
And Sharon, I want to ask you a similar question about the why not question about health, human resource planning. We talk about that. We've been talking about it. I've been around for 30 years. We've been talking about it. Oh, it's never done properly. Whose job is it to do it and to do it properly?
I think it's a great question. Is whose job is it, and whose responsibility is it? And I think that for a long time, we as physicians, we as educators, we as at the medical school, we have really largely done it, and without thinking really about the healthcare system as a whole. And I think this is the opportunity to think more broadly about it and to engage the health system on it, to do it in hopefully a more a strategy that's more aligned with what our population needs are. But up until now, it hasn't been done that way. And also, I think we've had a really big challenge in trying to come up with models that can predict over time what the big drivers are going to be. And I think now we have more data that can inform that can allow us, I think, to come up with more robust models.
And David, I want to talk about that with you as well. You did a whole panel on innovation. Is the problem people not taking responsibility for implementing the innovation? Is it lack of innovation? What's the root of the problem of not doing the stuff that works and scaling it up?
There's no shortage of innovation. The coast to coast to coast, there's a zillion great ideas. There's all kinds of evidence, as Sharon showed. Terrific blueprints, you heard from David, examples in the US. It's just a matter of the will and sometimes a little bit of working capital or seed money. And on that front, the cycle that has held us back repeatedly is we get serious about innovation and scaling it when the system is facing a fiscal crunch, which is exactly the time when there isn't a lot of spare change around to seed change and make the reforms work and scale. And so, the advice is somehow or other, when you're up against the wall financially, that's when you have to reach down and find some funding to scale and to spark innovation. It's a very tough situation for government, but if you wait until times are bad before you drive forward, that's what you have to do.
And in your report, again, you talk about some of that spark should be coming from the federal government. It's not all the provincial.
Yep. Yeah, absolutely. So very hard sell because, again, it's tough times. The provinces all want unconditional transfers. The Trudeau government's talking about conditions and tying it more to home care and community care, which is great. But the idea of actually putting the money in with pretty tight conditions around excellent projects for scaling and innovation, that's a tough sell when you're trying to get the front lines fed to actually provide basics of care for your citizens.
And don't forget, there's a mic up front. When you guys want to ask questions, I can ask them all day till the cows come home, but I want you guys to have a dialogue as well. David, I want to come back to you. You said in passing one of my favorite words that I like to write about, and that's culture, the culture of healthcare. How important is that to have a culture that wants to change, that wants to innovate, and what stifles culture?
So I would agree that culture is absolutely essential, and it's part of the whole team-based concept. So I would come back to if you enjoy your job, if you feel that you're able to make meaningful change, if you're having an impact on your patients, if it's the kind of environment where you're not frustrated all the time, you enjoy going to work, you get a culture of enjoyment out of it, but then a culture of innovation, a culture of creativity. So creating that culture is paramount, in my view, to a successful system.
And Peter, you mentioned that too, that we hear about the VA culture. Is that something that can be learned? Can it be taught? Can it be exported?
So what we found in the innovations that we picked up in terms of adopting the medical home is that you, as expected, you have a whole range of how successful they are. And one of the biggest predictors of success is a stable team, that you have a provider, a care manager, a medical associate, and a clerk. The 4 people work together as a team. But every time you get turnover of one of those, and especially with the clerks, who are the lowest paid of them, they tend to take other jobs. And so the team is constantly being disrupted. And so when you have a team that you can keep working with, I think the culture builds itself. But it's hard when there's a lot of turnover. That's one of the things we found.
And Bill, finally, I'll ask you to weigh in on that one. Is there a culture that's willing to have more integrated care in Alberta, or is it going to remain siloed?
Well, I think very definitely yes. I have to say, when I saw the information that had been compiled for the ministry by KPMG, I was a bit surprised to the extent that there is so much innovation that happens in Alberta. The Calgary Health Region and Capital Health and all the health regions, there were sincere and pretty concerted efforts at innovation. AHS has innovation on many fronts. Individual practices. I'm a patient at the Crowfoot Village Family Practice that has a blended capitation model. Tremendous care, tremendous innovation that's clearly at those sites. Yet despite microcultures that are focused on innovation and excellent patient care, the big picture isn't coming together right. So it's not, that's not a failing of the people, of the individuals in the system. It's a failing of how the whole system is incentivized and how things are structured. And that's why discussion of some of these bigger policy issues on how things are supposed to work together. And that can't happen through grassroots innovation. That has to happen through some higher level, the person who can turn the switch on and off. You know, those big things don't happen at the grassroots. I have tremendous faith in the professionalism of the individuals. It's just getting it all to work together.
And Carl, we heard about this. We heard the MA saying, you know, we want more integrated care. There's lots of examples, lots of success stories. Is the problem what Bill said? Is it a lack of incentives, a lack of the system, you know, rewarding this and saying this is important to doctors?
It may be possible to provide financial incentives, but I think that professional incentives are much more effective. Physicians will respond to the call to do a better job. And, you know, when you speak about culture, I think that's a very good subject. Leadership is an essential part of that, and physicians will be leaders. It does take courage and will on a system-wide basis to show that leadership, because change, not always welcome, but necessary.
Because there's always, when there's going to be a winner, when something changes, there's going to be a loser, presumably.
So that's a zero-sum game you're talking about. I think it's more complex than that. I think we can all be winners, and most especially patients.
Journalist math is pretty simple. So let's go to some questions. Again, tell us who you are. Fire off a question.
Sure, although you realize you are asking for a math is hard quote. But Catherine Andrewski from the Alberta Medical Association, and this may not be entirely fair because it might be actually for our moderator, but I was interested in what you were saying about the discussions that need to be had as far as what the system actually can afford to provide, what it should be providing, what patients expect it to provide, etc. When I was anticipating this forum and physicians as stewards, one of the big things, of course, that we can control in our day-to-day practices, I'm a GP, is ordering. So as far as investigations, imaging, consultations, all those sort of things, it isn't always the easiest of discussions, though, to have with a patient when they come in expecting something because they read it online, or their local pharmacist told them, or their friend told them, or whatever the source of information is. Some people in the room can tell you I'm stubborn enough that I will still have those discussions, and usually I can educate them, but they're not always comfortable to have. So how would you suggest we sort of expand that discussion from my office to globally within the Alberta healthcare system with patients?
Okay, great question. I'll flip it over to the real experts. So Sharon, that's a really important question. How do we say no to individual patients, and how do we, as a system, say no, we don't feel this is proper value that we're going to get from it, so we're not going to fund it? How do you make those tough decisions?
Yeah. So, and I think a couple of responses to that. One is to make sure that patients are engaged, that we're transparent in our discussions, and that patients are engaged in the decisions and the prioritization discussions that are happening. I think that's kind of a key principle. As an example of that in Ontario that we were involved with, so as people know, there was a systematic review that came out looking at if patients with type 2 diabetes who are on oral agents or are on no medications, they don't need to do self-glucose testing. And in Ontario, the test strips were covered by the ministry for everybody with type 2 diabetes. And there was a nice economic analysis that was done that showed that the government could save about $100 million a year by not covering glucose test strips. But as word started getting out around that, there was tremendous backlash from people saying that it was going to impact patient care and quality of care, and a huge amount of backlash against it, and the government really, the ministry really backed off on it for a while, and so then we started getting involved where we would engage patient groups around how should this be messaged, and making sure that the message wasn't around we're not going to pay for this anymore, but the money is going to be used for other things that potentially could have more of a benefit for the population, and so ultimately then it took about 2.5-3 years before it moved, but but I think it really highlighted the importance of engaging the patients in those discussions. And so now when we have those discussions around coverage of those types of issues, patients are at the table.
And Peter, maybe you could address that. We have the impression that in the U.S. you never say no, that patients get everything they want and more. But is there a way within VA of saying, no, this isn't cost effective, or to individual patients, no, we're not going to do this?
Yeah, so that actually comes up all the time, because then what they do is they just go to their congressman and make a complaint, and I get them on my desk. Why didn't I get this chemotherapeutic agent? Why didn't I get this procedure done? So, I think, again, some of it's the culture. We did some work a few years ago about talking to veterans about their perceptions of costs. And one of the really striking things that completely surprised me was their sensitivity to cost to the system. And that and maybe this is part of the military culture, or that they're part of a community, that they know that if things cost too much in one area, they're not going to have money in other areas to pay for things. Now, as a province or as a country, do you see healthcare as that way? I mean, I know you're extremely proud of healthcare, and who's that guy that was everybody?
Tommy Douglas.
Yeah, that guy. The Tommy Douglas guy. Which everybody in Canada knows who he is, the rest of us don't. But, you're very proud of your healthcare system for good reason, and maybe there is some, way to engage, patients and get them part of the discussion about, we only have a limited amount of resources. I mean, the oil sands will dry up at some point.
He's like our George Washington.
There you go.
And Mike, how do you, is it doctors' role to have this discussion about what we heard earlier, actual versus perceived needs? Is it the doctor's job to be the gatekeeper on that, or is it the system? Is it a combination?
I'm not the best person to answer that, but yeah, I think
but
that
this
is
surely
part of the
comes up
role.
in discussions,
Yeah.
in negotiations.
Yeah, and it is entering into it, and I do agree with some of the challenges that were noted, but strategies like choose wisely and so on, I do think is part of the, now I think there has to be support. The system often leads to it, that it's easier for people to take those steps and so on. And rather than supporting professionals and having those conversations, with patients, it's quite frankly easier just to go ahead and do the test or whatever. So I think there has to be a lot of improved support, and including, and so that the governments and all providers have to be involved in that conversation.
And in my experience as someone who talks to lots of patients, my impression is they don't mind being told no, that this isn't appropriate or whatever. What they don't like is when there's perceived unfairness, when they think somebody else is getting it and they're not. So I think that's it's a hard one to address. But go ahead.
Michael Jufrey, Calgary. I'm interested a little bit in Sharon's perception of the physician human resource planning or lack of planning that we have, because I think it is a very complex scenario. If we take into account that the demographic of physicians has obviously changed, that the gender ratio has changed substantially. And then when we look at the third factor, which is really the limit of resources within our institute, so particularly our procedural-based or surgery-based specialists, and why some of our physicians coming out can't get a job. Mm-hmm. You have to wonder whether or not, again, it boils down to not so much physicians being the stewards of a system, but a system that has morphed into something that is beyond the physician's control, that in fact those graduates, if they actually had ORs that they could get to, they would actually be employed. If we look at some of the wait lists, in spite of having so many more specialists within our divisions or departments, we have longer wait lists than we've ever had. Mm-hmm. And if we ask our physicians, particularly that do procedures, for example, surgeons, we have surgeons in Calgary that get a half a day a week of OR time. And they're paid on a ARP or however type of combined system. So again, it kind of points towards, yes, physician engagement, yes, physicians need to be stewards, but we need to be empowered in some way that gives us some control of a system that cannot accommodate us or our ability to influence the system.
And exactly, I agree with you that we as physicians cannot be doing this in isolation, that we have to think about working with in partnership across the system. Because as I said, and as you mentioned, a lot of these physicians that are running into trouble with jobs are ones that are requiring hospital resources. And so we can't just think about our needs as physicians, as individuals. We have to think about what the system needs, what our population needs are, and plan for it accordingly. Now, we're not always going to be able to be fantastic at predicting the future, but we have enough data now, and we know what's going to happen in our population over the next 10 years, for example, next 15 years. If currently things go down this pathway, we can create more accurate models than we have up until now that look at it from a system perspective, and I would really like to see that we do that, in addition to looking at what are the roles that the other members of our healthcare team can play, so that it's not just us as physicians that we're looking at when we're thinking about workforce planning, but the other members of our healthcare team as well. Because there's lots of things that my healthcare team does that they can do way better than I can as a physician. But how can we really optimize that when we're thinking about resource planning?
And David, do you want to weigh in?
Yeah, speaking first as an ex-dean of medicine, I can say the Ministry of Health used to send along to the deans in Ontario templates as to where the shortfalls were. So we had some signals. But as Sharon and others have said, the models were pretty crude. Let's assume the models are better. We're still going to have points where demographics and technology drive changes that we haven't predicted or anticipated. What they do in the Netherlands is the post-grad system is set up, as ours is starting to become, around competencies. They allow a lot more retooling. So if you're somewhere into your career, instead of saying, boy, you'll drop everything, you'll take a massive pay cut and go back to do a full residency, they provide accelerated retooling so you can revector your career effectively in your 40s. So we're going to have to be smarter about accommodating these shifts because they're going to happen faster all the time.
And I can tell you, this 2015 was the very first time since I've been at the University of Toronto that we actually had discussions around which specialties we were going to put trainees into and the numbers. We'd never had that discussion before. This was the first time where we actually talked about reducing numbers in certain specialties and how we were going to do that and basing it on population needs. And for that to happen for the first time in 2015, I think it was a little shocking.
So we have a number of people who are watching online, so I would just want to check somebody's monitoring to see if we have any online questions. I forget who, but no? Okay. Yeah, nothing at the back? Okay, great. So we'll go to someone who I know from the Twitter sphere who's here in real life, so go ahead.
Chris McCabe, I'm a health economist from the University of Alberta. I just wanted to ask, have the panel got any insights into how the health system can incentivize doctors and other clinicians operating within the system to reach out across the divide to other parts of government, the public sector, I guess, who do an awful lot to determine health, so into education, into social care. Most of the determinants of the need for the healthcare system lie outside of it, and it's very difficult for health system actors to reach across that divide. And I wonder whether the panel had any ideas for how we could incentivize doctors to look at those determinants and to reach out across those interfaces to improve the underlying health.
So David, do you want to start? How do you bridge that medicine and social welfare gap, and what's the role of doctors in doing so?
So there's probably two parts to my answer. The first is in terms of education. And as an educator, we have a responsibility to ensure that our graduates and medical students are thinking about it at a population health basis. And that has always been one of our challenges. We get into our siloed practice and we think about our patients and we do a really good job for our patients. We don't think about them in the greater context. The other part to the answer is creating a system where those conversations happen. So Ontario created something called Health Links a couple of years ago, which was looking at that 5% of the population that use 60, 70, however many percentage of the resources. And part of the work that we did was to bring, certainly in our own community, all of the various social services, community housing, et cetera, into a room. And when I had them all in the room for the first time, there was about 75 different agencies in Hamilton. And I said, so when was the last time everybody was in this room together? We've all got the same patients, clients, whatever you want to call them, when was the last time anybody got in the room together as a group? And it had never happened. I said, okay, how about half? It had never happened. And we really were able to drive it down that we were all working in silos, and it's a system challenge. So it was about purposefully bringing them all together and then using that as a model for particular patient phenotypes, if you will, and saying, how do we create the kind of system around which will stop them from utilizing the healthcare system as much as they are?
Bill?
I certainly embrace the notion of physicians advocating, and the CanMeds roles, the Royal College CanMeds roles, speak of 8 unique roles or 8 interrelated roles of physicians, one of which is the physician as advocate. And certainly advocating for upstream interventions that target the social determinants of health is important. I think it is essential, though, for physicians who do that to do so in a way that doesn't imply ownership of those issues. The physician voice will be heard, but education, housing, ultimately minimum wage public policy probably affects health far more than any single thing we've discussed today. So we could go home and say, yeah, we've wasted a day. It's about minimum wage and raising minimum wage, for example. So depending on whether you believe that or not. So it's that so I think a physician voice on those issues essential. It needs to be integrated with all the other people who care about that and the citizens who care about those issues. So.
And Carl, you want to weigh in on this one?
So I understand the question to be how to get physicians involved in other agencies or organizations that are concerned about the social determinants of health. I would suggest 3 steps. The first would be to inform or educate or teach physicians about those opportunities. Second would be to inform them about how those things align with their fundamental professionalism and their desire to serve the public good. And the third thing to do would be to get out of their way. And physicians will help.
And Sharon, a lot of your patients, older patients, many of them have as many socioeconomic needs as medical needs. Are we doing, back to the question, are we doing a good job of bridging that, of meeting the overall needs?
I think it's a fantastic question, and one of the things that we see a lot of, I work at St. Mike's, which is an inner city downtown Toronto hospital, and a lot of the patients that I see are in fact younger than the age of 65, but these are people who have been homeless for 35, 40 years and are having concerns with multiple chronic diseases, and so I don't see us as meeting their needs optimally, and I think it's going to be and in fact one of the things that I was talking to David Price about last night at dinner was about a tapestry that reaches out to the homeless population, the homeless seniors, because that hasn't something that's been addressed. So in some ways we're doing better. I think there's far more attention being paid now to aging than there was even 10 years ago, but we still have a ways to go.
And Peter, a lot of your clientele as well are veterans, people with a lot of socioeconomic issues as well as health issues. How do you deal with that at VA?
Yeah, so I'm going to push back a little bit on having the physician be the center of this. I can be argumentative because I'm just leaving town tomorrow, so you guys all have to work together. But I think having the physicians at the center of this is challenging because there is no way we can know everything. I mean, even within our healthcare system, I mean, I can't begin to understand all the resources that we offer to veterans, and I've been doing it for a long time, and they even get transportation offered to them, and there are all kinds of resources and things available that the social worker is better able to talk to them about, or the nurse care manager is able to work with the subspecialty case manager to coordinate care, and leave me out of it because I don't have the time to do that, and it allows them to work at the highest level of their training. So that's one of the things that we're really trying to do is get people to work at the highest level of their training and not have it all be on the physician.
But the key is what you said, it's coordination or having a patient navigator or something like that.
Yeah.
Yes, go ahead.
It's Glenn Sumner, Section of Cardiology from the AMA. This question is directed to Dr. Strauss. I think you made some very important points about high-impact, physician-based either decision-making or interventions that were clearly supported by evidence of very good or at least moderate outcomes. My question is, what are the best local strategies that for KT, essentially, to try to disseminate this, so much at the local level? It's very much a foundation in the academic world, but not so much with the individual physicians.
Just before you answer, I'm the acronym police, so knowledge translation, KT.
Oh, I'm sorry, yes, knowledge translation is KT.
But when we have a mixed audience, always, I think, important to avoid acronyms. So, yeah, go ahead.
Great, thank you very much. So thanks for the question. And again, there's not going to be a magic bullet. There's not a single answer, a single intervention that works from an implementation perspective. That's one of the reasons why I showed you the website, the RX for Change, because I think that's a great place to go to. And again, depending on who you're trying to target, whether it's health systems, healthcare professionals, patients, that's the website to go to, and it lists all the potential interventions. One of the interventions, for example, we've talked a lot about today was audit and feedback, people asking for data and being fed back to the clinicians. We know audit and feedback is effective. So when audit and feedback targeting clinicians, it changes behavior by about 7%. So it is an effective intervention, but there are certain key ingredients. So you need to have the audit, you need to have the feedback, and you need to have an actionable message. Just telling somebody that this is what you're doing and this is what other people are doing isn't sufficient. You need to have a message of action for somebody to be able to implement. And so I think that that to me is one of the things that hopefully we can do over the next little while is use the evidence around what interventions already work and start off with those rather than trying to think we have to come up with new things. And also make sure that we build in an evaluation if we're doing it.
Yeah, go ahead.
Hi, thanks. I'm Jill DeGrood from the W21C at the University of Calgary. Maybe, Bill, I'm just going to put your question earlier back to the panel. You had asked what's one thing that we can be doing. So maybe for each of you, what's one thing that tomorrow, if you could do, what would you do?
You stole my last question, but thank you.
Oh, good.
So who wants to start? Bill, why don't you start?
I wanted to wait and see if everyone did. I think the biggest thing, the biggest thing, and it can't be done tomorrow, but it's about governance for change. And governance involves figuring out who can make decisions and what the relationships are of people who are making decisions. And without a clarification around governance and then identifying a principle-based approach to the changes that need to happen, it's difficult. And it is really encouraging to have a day like today. I'm sitting up here, you probably can't appreciate the perspective, but just to look here and see CEO of AHS, executive VPs within AHS, the health minister was here, the president of the AMA is here, the executive director of the AMA is, all the leaders, so many of you are leaders here. It's an amazing collection of people, and there seems to be a real convergence around shared challenges. So if there can be this identification of what the challenges are, and then a dialogue around the stakeholders around, okay, how are we actually going to make decisions here, and how are we going to move forward? That's a bit of a diffuse answer, but it's about governance for change. If we don't figure out that piece of how the process of changing things will happen, we'll just be talking. And I'm a little nervous about David saying in his talk that he's been at these discussions for many, many cycles. I'd like this to be different, and I don't know if we can identify a shared commitment for making it different.
So Mike, what's the one thing you think we can do and could do tomorrow that's actionable that would help the system?
Actually, I would go back to something David Price said. We have put quite a lot of energy into primary care and operations at that level. There's a lot of good work going on in the acute care sector, but it's that connection and that integration. There's been a lot of thought given into that. There's been a lot of joint work done between AHS and primary care leadership and the physician community and so on, and supporting them in that work and empowering them to actually get that integration going and those connections. That would be the number one thing. And they have some ideas and plans on that, so supporting them in their leadership, I think, is the number one thing from my perspective.
So David, I'll jump down randomly to you just to keep you all on your toes.
Yeah.
So one of the big challenges, I think, is getting all physicians on the same track. And it won't happen easily, but part of it is the conversation so the reason you folks are here is because you're all leaders in the healthcare sector of one profession or another. And it's how do you engage your colleagues to start to be thinking about the future and the vision and how the system is going to evolve to meet all of your needs. And to me, that's the big challenge. And that's also, I believe, the challenge for the federal government is to start to articulate what the vision is for our healthcare system, because I haven't heard what our vision is for a Canadian healthcare system. We're so proud of our Canada Health Act. We talk about it. And somebody earlier on sort of described it as it's almost like our Magna Carta, but it's not become a living document. It has become a static document. And how is it that we move it towards a living document? So what can we do? We can start to understand and have the conversations about where it is that we're going.
And Sharon, what would you do tomorrow?
And that Tommy guy, yeah.
So kind of extending what Bill said about the governance approach and making sure that it's transparent, but that we're also building it on valid data so that we're measuring and that we've got good data that's going to inform our decisions and that we're also using evidence.
Very succinct, thank you. Carl?
The one thing that we could do, those of us in this room as leaders, is to claim the courage necessary to make Dr. Naylor's choice number 2 come to pass.
Peter, what thing would you suggest that Alberta does tomorrow to beef things up?
I'm going to go. I have 2 things, but one of them I think is practical. One isn't. I mean, I think promoting alternative payment plans. I mean, I think a fee-for-service model in the long run is a losing plan. I think we just can't have those perverse incentives that you just do more and you do more and you get paid more. I just don't think that's a long-term strategy. The thing that I wish you could do is an EMR that was integrated and linked. Getting back to Ken Kaiser, who used to head the VA, he said a few years ago at a meeting, he said, I'm hoping for the day when companies like Epic and Cerner don't need to exist because it will all be freeware. It will just be on the cloud and we all can use it and we can all benefit from it. And maybe Alberta can come up with that and then we can use it for free.
Now, David, you had many recommendations in your report. Is there one thing that Alberta could do tomorrow?
I'll go with action orientation. I think you have to keep talking, but I'd pick 5 things that you're already doing, because you're doing lots of good things. Prioritize those 5 and scale them. The second thing I'd do is, based on things you're not doing, but the literature shows or experience with rigorous evaluation shows are effective, my list would be more blended capitation with links to institutions, a demonstration project of an HMO, nonprofit, or IDS, integrated delivery system, and probably go as quickly as you can to bundled payment in a range of areas. Those would be my top 3. But I'd get those 3 that you're not doing, and I'd do them as fast as you can, because the longer you wait, the more likely it is the central agencies and finance minister will take the reins and drive cost cutting and capping and squeezing of fees. The more likely it is the conversation will go off the rails. So keep talking, but start acting right away.
So we're over time, and I know people have a bus to catch and flights to catch, but let's try and squeeze in one last quick question.
This is an email question from Dr. Van Zyl from the Central Zone Medical Staff Association, and I have forwarded this email to you, Dr. Galley, so if we run out of time to address it now, perhaps you can go later. But he asks, how do we move forward to have an actual integrated healthcare system that are representative, non-dictatorial, and equitable for both the provider and the receiver, bridge the service gap, and enable the primary care provider?
Well, that lends itself to a brief answer. Yeah. So, Dr. Galley, in 30 seconds or less, you could sum up the day.
Should we come back tomorrow? Yeah, maybe Dr. Price is suggesting we come back tomorrow. And maybe we start to do all the things that Jill DeGrood asked us to identify. Maybe I think that question is ultimately, in many ways, that's what we're working toward. That's what we're trying to achieve through this dialogue. and it's hard to really be succinct in answering that, though I actually did like just, I didn't want to go first in answering that. What's the one thing you would do? I think what I've heard is it's really a distillation of probably trying to phase out or at least reduce the extent to which fee-for-service drives our system. That's one. Integrated EMRs, that's the second. Evidence, that's been mentioned several times. And governance, which is much less exciting, but governance. I think those are some of the ingredients that we need.
So thanks to the panelists, and I'll leave it to you for a few closing comments. That segues right nicely into your closing.
All right, well, really not much more to say because we are over time, other than to thank everybody for coming. The audience has really been, has stayed the whole time, and we've had a long period of discussion. Very enriching. I want to thank all the speakers for their significant contributions to the program. Certainly want to thank Dr. Terrell and the whole team at the Institute of Health Economics, and then the tremendous team in the O'Brien Institute for Public Health at the University of Calgary. Thank you everyone for a very, very enriching day. And lastly, I want to thank the Ministry of Health for their significant sponsorship of today, and also the Alberta Medical Association. Again, I think we've all benefited from this, and I hope we have a shared commitment to keep the dialogue going and to identifying our solutions going forward. Thank you.